arrival. Take note of use the hotline instead of the transfer line. It's really important to always emphasize the ECG, the diagnosis of a STEMI, and when the EKG is done and interpreted is critical. And you'll see this in all STEMI papers. You have to get the ECG within 10 minutes. And you have to have somebody look at it, so you can't just do it. You have to have somebody see it and respond to it. Left bundle branch block is a whole kind of a separate talk in itself. You should know that even though we worry a lot about left bundle branch block, the number of patients where a brand new left bundle occurs in the setting of a fresh infarct, that is quite remote. So in terms of infarct causing new left bundle, that's a very unusual situation. More likely you have somebody who already has a left bundle but has an infarct and you can't see it. In equivocal situations where you're not sure, EKG doesn't match, history's so funny, the repeat EKG every 10 minutes can be really a critical thing. So if you leave the stickers on, leave the patient attached in some cases, and you just fire off an EKG every 10 minutes. And sometimes the second EKG or third EKG that diagnoses the STEMI and you can get the ball rolling. It's really frustrating when you see one at 30 minutes and then at 90 minutes, and that's the one that triggered the call. And patients who give lytic therapy, the standard, ACC standard here is to give it within 30 minutes. And I already mentioned, activating the transfer before the cardiologist gives us a call back. The call will be coming. We will accept the patient. We've reviewed EMTALA rules and everything with our lawyers and everything, and since the hotline nurse is a surrogate for the doctor and we have a notary policy, we can accept those patients. And I can't think of a case actually where a patient arrived on our doorstep where a cardiologist wasn't plugged in.
You can't.
I can't.
Thank you.
Can't. It's important for people in the emergency room or EMS people to just think about other diagnoses. We do occasionally run into situations. I'll go into this a little bit more when I review the EKGs, but we do occasionally get a type 1 aortic dissection here that can mask as an acute STEMI because this dissection can affect the coronary ostia and cause reduced coronary blood flow and ST elevation, or it can dissect into the pericardium and cause ST elevation from acute pericarditis from an aortic dissection. I've seen these cases. In fact, we had a patient on the coast get lytic therapy for a type 1 dissection because they had a STEMI on their EKG, brought it to the lab, figured it out within a few seconds. The patient was having a dissection and did an aortogram, and it showed the patient went right off to heart surgery and survived. Acute pericarditis, the demand ischemia, sometimes people are bleeding. You know, they have a hematocrit of 15, and they may have underlying coronary artery disease, and they're starting to have a heart attack because they're bleeding out and anemic, and those are people you wouldn't want to throw 600 of Plavix in and send them off for STEMI. So some simple awareness of these kinds of things. It seems silly, but it's really important. We've had occasionally lung pathology, lung tumors, pericardial mets from cancer show up and throw us off a bit. Just a few comments about some drug therapy here. When we use drug-eluting stents, which are really the standard and actually work better in the long run for STEMI patients compared to bare metal stents, we take some responsibility. When we put these stents in, we know the patient needs Plavix or clopidogrel for a whole year, can't miss a day kind of thing. We go over this time and time again with the patient while they're in the hospital, tell family members, give them a month's supply before they leave, all the things we need to do to get the message across, because the rate of stent thrombosis and heart attack goes up dramatically if you don't take Plavix. If you decide not to fill your prescription, if you leave it go on a trip and leave it at home or something else.
So could you explain the difference there between the drug-eluting stent and the non-drug-eluting stent?
Yeah, sure. The older fashioned stent, actually there are new versions of these stents that are really quite good, but the concept of a bare metal stent, the non-drug coated stent, when this stent is implanted, embedded in the wall of the artery, tissue grows over the stent and covers up the metal. That happens fairly rapidly with a bare metal stent. It happens in the first 2 to 4 weeks. That metal is covered up by tissue. One of the problems we have, though, with the recurrence rate or restenosis rate with the bare metal stent is in the range of 10 to 20%. And that's because some people have a very aggressive tissue growth process that fills up the stent. The stent doesn't break down or it's not damaging anything, but the tissue is growing right through the stent, filling up the artery. So it wasn't until 2003, actually, that they figured out, after trying all these various ways to try to prevent that process from happening, the way that worked is they coated these stents with drugs. And the first drug was sirolimus. So this is the Cordis stent. And what that drug does is it interferes with the growth process of the cells, so the cells take longer to grow back and cover up the metal stent. If you slow that process down, you get out to, a few months, 6 months later, and the process just shuts down. The switch that makes those cells grow just shuts down. So getting that drug on board early really dramatically drops the recurrence rate down to under 5% in most cases. But it exposed the patient to a risk. Since the metal is exposed to the bloodstream longer, there's a risk of a clot forming on the stent. That's why, in the early days, we had 3 to 6 months of Plavix on board for these patients, and we were finding more stent thromboses. That's why stents got a bad name, some of these drug-coated stents, because of the clotting. When clotting occurs in a drug-coated stent, it's usually a major heart attack and a major difference in survival. So it's something we take very seriously. Is that?
Yeah, then the reason why they have to take that Plavix longer is to prevent the clotting, whereas with the non-drug-eluting stent, they don't have to take the Plavix for quite so long.
Yeah, even though we tend to use Plavix after any heart attack, bare metal or drug-coated stent, we tend to favor Plavix for at least a year based on the CURE trial. It shows an improved outcome. In patients who might need surgery, elective surgery, or have some other increased risk of bleeding, maybe they're in atrial fibrillation, they really need to be on Coumadin. Other things, we tend to choose the bare metal stents in those patients because after that first month, the stent is at least endothelialized.
It also does seem like to be a key on an EMS call that somebody had a stent placed recently, and to query whether they're taking Plavix, because they cannot take Plavix.
Right, it's a good question to ask.
It's often the reason they call.
And to further complicate things, we have a new drug, and that's Prasugrel or Effient. And even the pharmacists in Astoria don't know what Effient is. My patients have told me. They went in to get their Effient. They didn't know what it was. They had to look it up. They had to find out to know what it was for. And so when you see Effient or Prasugrel, you need to realize that that's the kind of drug that is very similar to Plavix. And we were having trouble where we'd put a stent in, put the patient on Effient. The drug was brand new. They come to the coast. They couldn't get their prescription filled, and they wouldn't know what to do. They wouldn't call anyone, and there would be this problem. So we've gone through. We've had our mid-level providers contact the pharmacies, and we have a list of pharmacies we know carry the drug and that kind of thing. So when you're looking through the patient's drug list, you need to be aware of this. And when you see the patient and you're doing all the important things you have to do in the beginning, and you have a little time, if whoever does, it might be a good idea to start asking them a few questions. Have they had any blood in their stools, bad nosebleeds, blood in the urine? Do they have any planned surgeries coming up? Or are they getting something done? Maybe they have a major operation scheduled for a month from now. Have they had a stroke or a TIA? Because Prasugrel or Effient is contraindicated in patients who've had prior TIA and stroke. You could actually get sued, maybe effectively, if you didn't take the history and the doctor gave Effient in the emergency room. If you know that they have poor compliance, no insurance, financial stresses, these things may lead us to put a bare metal stent in, provide the patient with some Plavix, and not have to worry that they're going to not be able to buy their drugs later on. So these are things we think about. And every step, if people are kind of thinking about it in their head, in the ERs, and when they arrive, it sets up a better response and a more accurate decision. Just a little bit more about this Effient, Prasugrel. So this class of drugs is called thienoparidines. They're favored in some cases because they have a very rapid onset of action. So a patient lands on the table, we give them Plavix to inhibit their platelets. It can take up to 6 hours. We give them Effient within 2 hours we have near maximum platelet inhibition. So it makes a big difference to me as an interventionist to give a drug that's going to work right away, because we now use a drug called bivalirudin instead of heparin in the lab. It wears off in a few hours. Plavix hasn't kicked in. You have this hole where patients can get a clot forming in that first day. So anyway, this is a drug that's growing in its frequency of use, and it's a drug that will stick around, and you'll see that come up a lot. So some people, Plavix has to be metabolized through another layer before it has an active drug effect. And so this one has less of a metabolic change that has to occur before it's effective. There's a 60 milligram loading dose and 10 milligram daily maintenance dose. In elderly patients who are put on this drug, they may be on a 5 milligram dose. Although generally the package insert avoid if age greater than 75, weight under 60 kilos. So small people, old people, prior stroke or TIA, best to avoid that drug. It's actually been proven that platelet function testing, we thought when I made this slide, may help patient selection, but some recent studies have not supported that yet. So right now there's no magic test we can see. There's some discussion we can have about that, but the main thing is to know that we don't have a simple platelet test to know if it's working well and it's going to help the patient. This is the trial that put Effient on the maps, the Triton-TIMI 38 trial, compared the two drugs, Plavix and Effient, in over 13,000 patients. And we get a benefit of better endpoint death, non-fatal and minor stroke, at the cost of some increase in bleeding. So patients at increased bleeding risk should not get the drug. Just a couple other simple safety issues here. For people in the emergency room, we do care about creatinine clearance. It's important to give the right dose of anticoagulant, heparin, when we're adjusting this. So something to think about. We do want to avoid excess unfractionated heparin, and patients who receive lytic therapy should never exceed 4,000 units, no matter how big they are. Right now, our order sets don't differentiate this, so we have the same comments in our non-lytic therapy patients, but this has been discussed recently, and things will probably change. So if you have a bigger patient, 110 kilo patient with no lytic therapy, probably will be using 60 units per kilo as a bolus. And usually we don't start drips just to save time. So even we want to get an adequate bolus on board, and hopefully carry the patient until they get close to us, and we'll take it from there. I usually switch them to this other drug, bivalirudin, when they're in the lab. I won't go through Ortistat. I don't think this is